Welcome, everyone. I am Elizabeth Gamotes. I am the Chief Operating Officer for the Association of Academic Health Centers International, and I bring you greetings on behalf of our president, Dr. Stephen Cantor, who couldn't be here today. But we are just delighted to be welcoming everyone to this inaugural meeting of our regional office in Eastern Africa, which has been a vision for some of the organizations in your area and AAHCI for some time. And so this is a proud moment. And I want to thank the leadership of the Aga Khan University in standing up your office, and in particular, Dr. Macharia and his team. And I am particularly delighted to get to greet you today because I had the pleasure of being in Tanzania in Dar es Salaam 2 years ago for your East Africa Health Scientific Conference. And I got to meet some of you in person and see the quality of leadership you have at your organizations and hear the conversations you were having about establishing a networked system of your academic healthcare institutions in your region to be able to drive sustainable population health. And your discussions in that meeting were really quite prescient, given what the world has seen over the past 16 months with the pandemic. And as you all know from what you have on your agenda today to discuss. And I think that the pandemic has truly pointed out the need for global coordination of academic health systems across the world and also within specific regions. And it's also pointed out the tremendous fragility of those systems. I know you all are talking about the fragility of your systems in East Africa, but I will assure you that we are having conversations like this around the globe with our membership. And whether you're in Sao Paulo in Brazil, or Singapore, or Italy, or the United States, there are distressingly shared challenges about institutional fragility, about population health fragility, and what the pandemic has made completely starkly evident is how much we are all in this together. And so we have long wanted to have a structure in Africa and in East Africa to be able to bring your voices to our global membership. So it is really a privilege to be with you today. And I really look forward to the conversations. I want to thank William for your leadership, and Eunice on your team. I'm sure you're out there listening and you bear a lot of the credit for today's success. I want to thank Dr. Amakoye for moderating today. I know we're about to lose your leadership, which is unfortunate. But I want to thank you and all of you who have worked so hard to bring this group together. I think your voices are important to our global membership, and we look forward to supporting the work you all are doing in the region. So thanks for letting me join you. I hope someday soon I'm back there in person again, not having to talk about time changes and connections. So William, I will turn it over to you.
Thank you very much, Elizabeth. That we highly appreciate you stepping in for the CEO, who unfortunately we were informed was not able to join us, but we are perfectly okay with the officiating and opening this meeting. I'm making this welcome address on behalf of the advisory board members, who are 5 of them, for the Association of Academic Association of Academic Health Centers International. And these are at the moment represented by Makerere University, Kampala International, Kenyatta University, Kenya Medical Research Institute. We have Dr. Mukoe here, who is facilitating this session, and of course, Aga Khan University. The reason for having this association in place, which is a global one, is so that it can promote dialogue and learnings across many different medical centers in the world and within the regions who have got tripartite mandate for research, clinical services, and education. And this is ours is the latest of the different regional entities of the association. And we have only been there for about maybe just over a year, and we are in active process of inviting new members. We anticipate that pretty soon Ethiopia, Tanzania, Burundi, and Rwanda will be able to join us. So I'm also honored to have you as participants coming for this session. Without you, of course, we wouldn't have this first CME for the region. And I also thank those who are behind the scenes, as Habiba and Eunice, for what they've been doing to make this possible. So I would also like to finally appreciate today's speakers who have been sourced from different countries to give us a truly international experience with on management of COVID. So not everything is bad about COVID. We know it has devastated the world, but there's a silver lining because it's the one which has made this kind of platform so popular to give us the kind of audience we have. Thank you very much, and welcome to the session. I hand over to the facilitator, Dr. Ivan Zamukoy. Thanks.
Thank you so much, Elizabeth Gimots and Professor William Masharia, and welcome all to the first AAHCI Eastern Africa webinar. And we're excited to have all of you here. The goal of this webinar on diagnostic management and preventive measure of COVID-19 will be to share unique experiences from academic health centers in East Africa, specifically on how fragile health centers have been saturated since the first case of COVID-19 were reported. As you are all aware, the number of hospital beds in our region, by and large, are limited, and more so the ICU beds, ventilators and qualified staff to man them. In the beginning of this pandemic, air transport and other transport were disrupted, affecting supplies to our region. This, in a way, was a blessing in disguise. We know that there are very many materials that could actually be made within our region that we can take advantage of. For example, like Uganda can actually supply almost all the ARVs we want in our region. We know that Rwanda and even Kenya is the process of beginning to start vaccine manufacturing. And in Kenya, where I am based, we know that we actually were able now to be self-sufficient in PPEs, and we're able also to, in my home institution, Cambridge, we can say we started supplying actually sodium hypochlorite, sanitizers, virus transport media, and very soon we'll be supplying PCR kits. So this actually, in a way, has been a blessing. So we will now hear from our panelists and then have facilitated discussion. If you have any questions throughout the presentation, please insert them in the Q&A feature and or the chat box. Our first speaker will be Dr. Rina Shah. Dr. Rina Shah is an associate professor and section head of infectious disease in the Department of Medicine, Aga Khan University Hospital. She received an MBBS degree at the University of Southampton in UK, and both her master's degrees and diploma in infectious disease from University of London, UK. She also holds diploma in tropical medicine, infectious disease from London School of Tropical Medicine and Hygiene. Dr. Shah has held several positions, including program director for internal medicine resident program, interim chair, Department of Medicine, and is currently the director for infectious disease fellowship program at Aga Khan University Hospital. Her scholarly area of interest is infectious disease with specific focus on HIV, AIDS, TB, malaria, hepatitis B, and now COVID-19. In Kenya, these diseases are of prime public health importance, and there's a tremendous need for applied research, development of improved diagnostics and therapeutic strategies, development of guidance and contribution to national policies. She's a vice chair of the HIV Clinician Society and part of the National Task Force for COVID-19 response. And I know we meet Rina when we start discussing about TB. Welcome, Dr. Rina Shah.
Thank you, Dr. Evans Amukoy, for such a kind introduction. So this is where I work. This is Aga Khan University Hospital, Nairobi. And I'll plunge straight in. So we know globally as of yesterday, we had about 167 million cases of COVID-19 with 3.5 million deaths. In Africa, we've had about 4.7 million with about 128,000 deaths, giving us a mortality of 2.6%. In Kenya, so far as in earlier this week, we'd had 168,000 cases, more men than women, and that's, I think, seen across the globe. And our deaths are about 3,050. So we have a case fatality rate of 1.8%. As I speak, we've had 3 waves of the COVID-19 pandemic. The first one was in July last year, the second one was November last year, and the third one is we're just coming out of it. It's just like this first week that we as infectious disease doctors have relaxed in terms of the numbers of patients we have in Nairobi in our hospital. So, so as with the waves, we can see that the trends of the deaths follow this. So as we have the waves, it's expected the deaths follow. And as shown world over, that majority of the cases are mild. A certain percentage are severe, and critical is 4.7%. And the reason we worry about this is that the disease is so infectious that if a lot of patients got infected, even if we had like 100,000 infections, 4.7% requiring ICU beds would overwhelm our healthcare system. And that's why we need to control the pandemic. Having said that, if we look at Kenya, our data here is majority of our patients are asymptomatic. We're at 91%. Our symptomatic are very, very few, and that's good for us. That would help our healthcare, because our ICU beds in the country are less than 200. Of course, majority of the symptoms are cough, fever, and difficulty in breathing. And I'll come back to this later. Sorry, the deaths also follow, like there's a lot more men who are infected than women, and a lot more men hence die. But if we look at the age bracket of our deaths, and it mirrors what we see in our hospital, is the 30 to 60-year-olds that are more likely to get infected and die as opposed to the West. And that's the people we need to target when we talk about how we're going to put in strategies. So, as we all know, it's the second week that's very important. You can have infection, and the first week you have your symptoms, but it's the second week when patients get more dyspneic and require critical care admission. So I think one of the messages that goes out is if you're okay in the first few days, do not relax, continue measuring your oxygen saturations and temperatures until 14 days are over. We know the primary symptoms, and I'm not going to go through all these, but as the pandemic has evolved, we're seeing a lot more presentations with the secondary symptoms. And literally, this is anything that can come into hospital. So literally any symptom that comes to hospital can mimic COVID-19. So what is COVID-19? And this is the case that we have followed in our hospital. Anyone with acute onset of fever or cough, or any 3 of the following: fever, cough, weakness, myalgia, sore throat, nausea, vomiting, diarrhea, or somebody with a suspect case of chest findings through imaging of COVID-19, a recent onset of loss of smell or taste, or absence when there's no other cause for that, or an unexplained death in an adult with respiratory distress. And what about the diagnostic? And I want to talk a little bit about this, because this is where we've been caught out. We say diagnosis is when somebody has a positive RT-PCR. But remember, and I must reiterate, that 1 or more negative results does not rule out the possibility of SARS-CoV-2 infection. And the reasons is you could have a poor specimen collection, the timing could be wrong, it's not being handled properly. So when you have a high index of suspicion of COVID-19, especially when you've only taken an upper respiratory sample, try and get a lower respiratory sample. At any one time, we do have a couple of patients in the ward where they've had a negative PCR, but we believe that they're positive, and we go on to look for other samples such as sputum, or do a bronchoscopy and get a sample, and the patient does turn out positive. So this is one very important lesson that we've learned as the pandemic has evolved. And the reason for this is we know that the sensitivity is higher the lower down the respiratory tract. We go look at the first 2 lines. Upper respiratory tract sensitivity 76, while lower respiratory tract is 89. I'm not going to go into a lot of details about these slides because they're all going to be available on the net after this talk is over. So as an institution, we've been doing this. We have been monitoring the pandemic, and what we see in the hospital echoes what the country is seeing. And I think that's really important to help us monitor what is happening. And this is studied by the task force that we have in the hospital, who I'm going to talk about later as the talk goes. I mentioned this CT scan abnormalities, but if you look at what I've highlighted in red, in this study, 60 to 93% of patients had initial positive CT scan consistent with COVID-19 before the initial RT-PCR result. So in a lot of institutions, the PCR can take anything from 8 hours to 24 hours to come out, but a CT scan takes an hour. You can, as soon as it's done, you have a look at it. So that has helped us manage these patients better because we can isolate them, know what to do with them. And in our hospital, we have been doing a lot of CT scans in patients that we suspect to have COVID-19. This is a very interesting study from the UK, which shows that literally patients with COVID can present with anything. And as the pandemic falls, you've got to have a very, very low index of suspicion for COVID-19. So following this, and thanks to our senior leadership team, all patients that have been coming into our hospital since March 2020 have had a pre-admission COVID test. So this includes patients who we believe have COVID. So somebody, for example, who comes in for a routine cesarean section will have a pre-admission COVID test to see whether they're positive or negative. And this is pandemic measures. And what we have found, and we have our infection control team, this is going to be a paper we're hoping to publish very soon, that we have found out of all the patients we tested in 2020, that came into our hospital, 1% had incidental COVID. So these are not patients who went to the COVID ward. These are the patients who went to maternity, daycare surgery, routine surgery, orthopedic, came in with an RTA. Incidental COVID is 1%. And how has that helped us? It has helped patients that they know whether they have COVID or not when they come in. It's assured the caregivers, us, as we go without our full PPE to see patients. Remember, we not only see COVID patients, we see other patients. So it's assured us, and it's reduced anxiety amongst patients and staff. And our infection control team is actually going to hand out a questionnaire to all the staff to see, does that help and has it helped? And we're hoping to publish this pretty soon. So when we look at the severity of COVID-19, you've got to have this in your mind. Has the patient got asymptomatic disease? Are they mild? Are they moderate? And asymptomatic is no symptoms. Mild illness is the normal URTI symptoms that we get when we have a flu or a cold. Moderate disease is when your saturations are greater than 94, but you have normal imaging. Severe illness is less than 94 saturation, and critical illness is when you're in respiratory failure shock. And the reason I'm talking about this is the last two lines is severe illness and critical illness, where medical management and admission to hospital is of utmost importance. The first three can be managed at home. And this is important because the NIH and the IDSA has given guidelines on who you treat. And what has happened in a lot of countries and out in primary healthcare is everybody with COVID gets treatment with everything. Like everybody will get steroids, everybody will get antibiotics, etc. So there have to be certain guidelines. And in our hospital, we've come up with guidelines in who we treat with what. And we've distributed that in the country, and anybody is privy to use them if they want. And basically all it says is hospital patients with critical COVID-19 with low saturations are the ones where you give dexamethasone. If your saturations are greater than 94%, you do not need it. The other drug that is used is tocilizumab, and you give it to patients who have progressive. So on dexamethasone, if the disease is progressing and the inflammatory markers are going up. And it says that a lot of things such as baricitinib, convalescent plasma, etc., should only be used in a clinical trial setup. And the reason for this is just one study that I'm going to share with you is the recovery study, which looked at patients who were given usual care or the standard of care vis-a-vis dexamethasone plus usual care. And if you look at the y-axis, patients with dexamethasone overall had a reduction in mortality. But if you look on the right side, if you subdivided these patients and the patients who did not require oxygen and you gave them dexamethasone, they had an increased mortality. So drugs are not benign. If there's one message I want to send out is drugs are not benign. If you give something where it's not recommended, it can actually be detrimental. And in our hospital, if a patient does not require oxygen, we do not give them dexamethasone. Where the same study, again, another sub-analysis, so patients who were on oxygen and required invasive mechanical ventilation both had a lower mortality with dexamethasone. So only patients who require oxygen and require invasive mechanical ventilation benefit from dexamethasone. And it's really important to do this, because if you're going to treat somebody with something that's not required, you can cause this, like what's happening in India. India, there's been a lot of abuse of steroids. Everyone, even outpatients, mild disease, asymptomatic, are going into the pharmacies and buying steroids. And this is what is happening. So remember, drugs are not benign. When we think of, and why is it that only at a certain time can you use steroids? Because when you think of COVID-19, you've got to think of it as phases. The early infective phase is a viral phase. So there's viral replication going on. If you give steroids at that time, you'll probably not be able to clear the virus. But as the virus clears from the body and the patient continues to deteriorate, is when your host inflammatory response comes in. And that is when dexamethasone is useful at the same time as giving the patient oxygen. And that is the theory behind why early steroids do not help. So, and remember, every patient can go from one stage to the next stage, or they can improve. So you can go from stage 1 to improvement. You can go from stage 1 to stage 2 to improvement, and stage 3 to death or improvement. So there can be improvement at each stage, but you've got to know how to manage the patient well. And our hospital has come up with protocols and guidelines on how to manage these patients. I just want to say that when we manage these patients, especially in pandemic, we've got to do all three. You've got to have best evidence with clinical expertise, and give evidence-based medicine. It's been we've seen how we've come, initially everybody was given hydroxychloroquine. We now know that it doesn't work. Again, it's evidence-based medicine that showed it doesn't work. Antibiotics don't work. So this is something, and I must say that we do try and do this to give our patients the best evidence-based medicine in quality, especially as a teaching hospital. So this is a prescription that I saw on a patient who had asymptomatic COVID-19. Really, do we need all this? The answer is no. And it's a very nice article here, it came in the New England last year, that COVID-19 has to give us a reminder to reason. You've got to reason why you're giving your patient the treatment that you do. And this could be simplified into just paracetamol as required. And we need to bring that message out to all the practitioners in the hospital, in the region, everywhere, that this is what is the best for the patient. And NIH has come up with guidelines to say there's a lot of these don't work now. Azithro doesn't work, hydroxychloroquine, there's a lot of media, there's a lot of WhatsApp messages, lots of things going on that tell you, put your patient on this, but these do not work, right? So no azithro, no hydroxychloroquine, no ivermectin, no colchicine. Antibiotics do not work empirically. Steroids when oxygen is not required. So, and having said that, the NIH has gone another step ahead to say that it recommends against using these drugs. You don't often get this in a lot of diseases, but COVID-19 and irrational use of a lot of drugs has led them to come up with this to say we recommend against it, that it actually is detrimental if you use these medications. So what should we do? I think we must do clinical trials. Clinical trials must be done in Africa because it's our population. And that would tell us and help us manage our patients better. So I just want to talk about Impacta, which is a study that we were part of as Aga Khan University Hospital. We're very proud to be the only hospital in Eastern Central Africa to be chosen to be part of this study. And basically, this was early last year, around July last year, when there wasn't that much data on immunomodulators. So we gave our patients placebo plus standard of care vis-a-vis tocilizumab. Of course, I didn't know which patient got what. And the outcome was that patients in the tocilizumab arm had a 12% reduction in mechanical ventilation as opposed to the placebo arm, where it was 19%. So there was benefit, and following this has entered the NIH guidelines for patients who are on steroids and are deteriorating. So we're happy. We've used this drug, we've used it in our population, and it works. And I think the future for medical care in Africa has to be led by randomized controlled trials. So let me shift gears to infection prevention. How do you prevent yourself from getting infected? First you've got to know the status of your patient, but Sometimes you don't. And in routine patient care, in the clinics where you're not going to test every patient that walks into the clinic, what do we use? So this is what we've adopted. For routine patient care, we use surgical masks. But if you think there's a high index of suspicion, like if you have a patient who's coughing all over, put on your N95. But if there's aerosol generating procedures, you've got to use an N95 mask. And our hospital has ensured that this is available. And then they've done it by rationalizing the use of these surgical masks. So we know high risk areas, low risk areas. And every week, twice a week, there's a report saying these are the masks that are used here. So suddenly, if in the canteen, if there are lots of N95 masks being used, antenna go up, as opposed to, say, the operating theater or ICU. So when you have a patient with COVID-19, when do you de-isolate them? And this is a very interesting strategy, again, that we've adopted, we've adopted the symptom-based strategy, which the CDC has then gone on to also adopt. And basically you have somebody who has COVID-19, but has had resolution of fever for more than 24 hours, and improvement in symptoms, and more than 10 days since symptom onset for mild to moderate illness, and more than 20 days for severe to critical illness. So somebody who's required oxygen 20 to 21 days before we isolate them, even in the ward. So if they're in ICU for 21 days, at 21 days, we drop isolation. We don't retest. Retest is not recommended because majority of cases results in prolonged isolation of patients who continue to shed detectable RNA but are no longer infections. And there's lots of studies that have been published in Science that show that after this period of time, patients are not infectious. And this is shown, if you look at this graph, I know it's a busy graph, but if you look at the blue and the green lines, the blue is nasopharyngeal virus, and the green is bronchoalveolar lavage. And if you look, there's a certain percentage of patients, even beyond week 6, that will continue to shed the virus, but we know that they're not infectious. So if you ended up testing everybody at the end of their illness, a lot of patients would remain positive but are not infectious. So the government of Kenya and world over, the repeat testing is no longer recommended, and we don't recommend it at our hospital. So we've had an Aga Khan University Hospital task force, and that's really helped address the issues. And I think that has really put the pandemic in perspective in how we've managed it. And it consists of the senior leadership, the CEO, dean, nursing leadership, chief operating officer, and chief of staff, all clinical departments, nursing, pharmacy, MMD, laboratory, IT research, all come in on a daily basis or minimum 3 times a week to discuss whatever issues they're having. Are we having bed issues from the clinical side? The pharmacy will say that the drugs are shortage. This is the stock we have. MMD will tell us how much gloves they have, N95, what can we do? Where can we procure for? Everyone comes in, and that has really helped manage the pandemic, and we're already meeting to discuss the next wave. And with the senior leadership buy-in to this has helped us address a lot of issues, and I thank them for helping us walk through this. So as I come to the end of my talk, this is really uncharted waters. There are no experts. We've all learned from each other, and it has to be a multidisciplinary approach. There has to be need for networking, as we're doing now, and learning from each other. Of course, hand washing, social distancing is very important, but you need to have a diagnosis with a high index of suspicion. Like I said, you've got to look for lower respiratory tract samples when you believe that you don't believe the results, CT scans, etc. And there's no role for regular repeat testing. We abandoned that a long time ago. And my question is, should all hospitals in the region adopt routine testing in the pandemic with the incidental that you find? Because if you have a bed
Okay. Thank you, Rina.
Yes, I think, Dr. Shah, I think we lost you in the connection. But Dr. Mukoyi, let's proceed with the next presentation, and she can add any last points at the discussion.
Okay, thank you, Rina. I know the discussion was so exciting, but the next speakers, please, let's try to keep on time, 15 minutes. So the next speaker will be Manelas Nkeshimana. Dr. Manelas Nkeshimana has MBBS Honors from Taijin Medical University, China. ML Internal Medicine from the University of Rwanda, and an MSc in Global Health Delivery from University of Global Health Equity. He is an internal medicine physician and the head of Accident and Emergency Department at the University Teaching Hospital of Kigali. He is a COVID-19 frontliner in Rwanda, leading the subcell in charge of case management at the Rwanda Joint Task Force COVID-19 and a clinical lecturer at the University of Rwanda. He is the vice president of the Rwanda Medical Association, and his research interests are vitamin B12 deficiency, sepsis, and HIV/AIDS. Welcome, Dr.
I thank you very much for this invitation, and thank you for the kind introduction and the invitation sent to us. We start with a summary. It's a bit of unconventional. I want to highlight a few things that I want as a key message from this conversation. One of the things that we are going to remember now and beyond is that whenever we face a health threat of similar magnitude, spending and investing a lot in preparedness is very crucial, because we knew ahead of time that our health system was about to be overrun. So we put our resources together to ensure that we don't get where we did not want to go. And this goes to always consider whatever is circulating around in terms of epidemic intelligence services that we have across the world. Coordination structure is very vital. COVID-19 it's one of the threats that is evidencing that we should not leave all the matters to the healthcare providers. The role of collaboration, which is multi-sectoral, is very, very crucial. We should not parachute in people's lives overnight and instruct them what to do. There should be a conversation with the population we serve and at the level that they can understand best, and we should earn their trust if ever we have to be successful in the containment of such health threat. We should think beyond borders, because COVID-19 has demonstrated to all of us that there is a lot we need to do beyond our nations, beyond our countries. There are a lot of conversation that should happen between academia across countries, between all sectors beyond our own nations, because this is a global health threat and it requires a global response. Data is key. Trust your data, collect your data and trust your data, and base your decision on top of that. And for Rwanda, we are very lucky. This was an all-government response. It was very, very usual, very common to find a minister tasked to oversee a treatment center operation day to day, from Monday to Sunday, be answerable to even details like, did they have something to eat? Did they have their medication on time? This was an all-government response that we are very much appreciative of. COVID-19 is something that we are going to remember. It's not a cross-section something. It's not something that is going to end today or tomorrow. We are going to be dealing with the great consequences that is going to leave behind and affect the generation to come, because everyone's trajectory across all age group have greatly been modified, and you are going to have sequelae in terms of finance, in terms of psychology, in terms of physical damage that it has amounted so far. And if you look back in history, it's not the first time that we deal with such threats. If you look at the PPEs that we have today and the PPEs at the time of the Black Doctor, it's the same essence is there. It's just the science that have evolved. And COVID-19 was with a very heavy death toll in certain regions of this world, as it was by the time of bubonic plague. And some countries have been lucky enough to not amount heavy deaths. And considering that this is not the end of it, we are going to have more of these episodes in the future. It's time that we collect and reflect and reposition ourselves collectively to respond much better in the future. Vaccines, you have heard a lot of vaccines. The conversation about vaccines in Africa has always been very difficult. But if we use the history of medicine, there is a way we can tell the population that we serve the ways to understand vaccines. We don't have COVID-19 vocabulary in Kinyarwanda, for example. So if you walk in someone's house, I'm vaccinating you against COVID-19, they will ask you, name it in my local language. And we don't have this vocabulary. So there are techniques that we need to use. We need to be flexible and understand people in their local contexts as well. So this is the coordination structure for the COVID-19 response since the very beginning. You see a lot of stakeholders. You see the government in the National Steering Committee. This is the Prime Minister's office who has to draft a summary every night and submit to the High Office. And as you go down, I want to draw your attention to the expert advisory group. This is where the academia plays a great role to ensure that the data is being collected and is serving people who are based down here on the operation cells, the administration cells, the communication cell, the current planning, future planning, and documentation, because by the end of the day, we need to properly document what you have been doing since the very beginning. We have been lucky to have well-committed, patriotic nurses and doctors and paramedics equipped with good communication. We have created relationships with security organs because if you partner with these groups, you are sure of precision and quick actions. We have very good results and success that we have registered, but underneath this success, we have nurses that we are collapsing on the bench in treatment centers, having worked heavy duties and night shift that you are very long beyond. And this is something that you should appreciate and ensure that you have the staff that are equally committed as we face the future full of many similar health threats. One of the reasons that you should remember, do not mix COVID. We do not mix COVID-19 patients with other patients, and this is going to be applicable for many situations that we face in the future. So train well your team, update them on the knowledge on the disease that you're facing, and establish clinical areas where you have to take care of these patients. So this is one, the COVID-19 referral hospital that we have in Kigali that can provide mechanical ventilation and other high-end treatment for people in need of hospital-based care. We have been very lucky, and I repeat this all the time, it's not very often that from the onset of a new disease, you identify the causative agent very timely as it has been for COVID-19. And you see difference in timelines for SARS-CoV-1 and SARS-CoV-2. For the identification of the causative agent for SARS-CoV-2 was very timely, and this allowed the manufacturer to have the therapeutics sometimes, or the ideas on what should be the therapeutics and ideas on what should be the testing primers for this pathogen. Could it have been very long? We would be facing great consequences as we speak. Of course, the global interest in vaccine development was never seen before, and this has something to do with a devastating disease as we have seen in Brazil, or the European continent, and the Americas. The laboratory capacity at the onset in Rwanda was very basic. Only Kigali was able to test for COVID-19. And very quickly, we had to catch up and ensure that all the provinces in Rwanda are covered with this testing capability. You don't want someone to walk kilometers and kilometers from their village to access a test that is very far located. They will not turn up for the test. And also, you lose the opportunity to control disease within your country. And you have heard, of course, the pooling approach for massive testing, where you group the tests and of people who share the same epidemiological link, and you only have to test one by one if the pool is reported positive. This has also put us ahead of the pandemic. It's a devastating disease. I'm not going to repeat this. It is a disease that was devastating for the young, equally for the old. There are a lot of rumors that this is of the elderly, but very quickly we understood that we need to protect all the groups that we have because the mortality was there, even for the 20 years old and younger than that. Reality is complicated. We had to adjust our response mechanism, rural versus urban, because they don't share the same realities. They don't have the same knowledge. So we needed to adjust our response according to where we are tasked to operate it from. This is where we are today. We have had two waves, and we always remember that the second wave in Rwanda was associated with high mortality. And for the last few months, we see a stable disease with little flares that we intend to understand as day goes by. We do regular testing and internal mapping for all districts of Rwanda to see where we have disease activity that is higher, and we go ahead and understand why is that the reason, because there is always a why. And this test has to happen very regularly. We do go to all sectors and draw a sample and establish those maps. And whenever we have a province, let's say Bugesera, which is on top on this slide, is associated with underground prayers, we'll go ahead and engage the religious leaders and have their buy-in so that they help us to move ahead of this pandemic. And across the other sectors and districts also, they have different realities that we very much invite the academia to go deep and dig what is the biosocial reasons that these areas are associated with flares that are threatening to set a fire again on this pandemic. Guideline management, we started very basic. We did have very little understanding of the disease. And as we progressed, we did understand a few things like silent hypoxia and planned as well what to do. We did have a challenge, what to do with a mother who's positive and the child is negative, what to do with a child who is positive and the mother is negative. But using the experience we had with HIV, that we should never, or we should resist to separate the under 5 from their mothers. The third edition guideline, that's where we find the choice of antibiotics, because concurrent bacterial infections are very common. We did understand more of the dexamethasone role, as it was highlighted by my colleague, the use of anticoagulant. How should you continue the essential services? Because you can have COVID and you are in need of emergency care. We did reflect a bit on remdesivir and the convalescent plasma, but these are the drugs that we are used in Rwanda. And again, home-based care is something that had to set in very quickly. We did use monoclonal antibodies for mild disease for people for whom we are sure that we are likely to decompensate: the obese, the diabetic, people with concurrent heavy comorbidities such as renal failure, cancer chemotherapy. We did provide them with bamlanivimab, in the category of monoclonal antibody. Favipiravir is one of the drugs that we have used, and you have data that it allowed us to clear the virus shorter than as opposed to those who are not on favipiravir. Ivermectin is something that is very new. I put here on the slide, but we are still looking at the data around it, especially using the cohorts from Rwanda to see what it does signal as an outcome. There is a lot of reason that you should invest in therapeutics and vaccines, because at age 56 in our countries, we are talking about people who are ministers, church leaders, people who have a very great role in the community, and their death is something that we can't afford. So anything that we have to put in at whatever cost, being therapeutics, being vaccine, this is something that we have to base on, because their death is very devastating. We aim to have early suspicion, early diagnosis, early treatment, and early referral from the village to escalate the referral pathway if any component of the COVID cocktail is missing at any particular level. We use technology to map the contact high-risk zones so that we can invest more in these areas using mathematical models that are availed when we partnered with people in mathematics and other departments. The use of robots in limiting the exposure of healthcare workers or during the decontamination process. This is something that we did value. The use of bracelets to ensure that the people in home-based care are following the recommendation made by the doctor, the use of pulse oximetry in all patients in home-based care to ensure that they are not developing a severe pneumonia that require hospital-based care. Vaccine work, there's no doubt about that. We are all excited to get our second doses. And we, unfortunately, as we speak in Rwanda, we are about 3% of the target of the people to vaccinate. And we are trying to outsource, to partner with people and use the network, the COVAX, African CDC, so that our population, at least 60%, they are vaccinated and on time. We did partner in the rollout of 3% that we are vaccinated. We did partner with several people, security organs, the chemists, and everyone to ensure that we have well positioned to deliver this vaccine timely by ensuring that the staff space and systems are very well thought of in the preparatory phase before the rollout of vaccines. The minister himself was the very first to be vaccinated, so that the population is very trusting and they turn out to the rendezvous. We did do a pre-vaccine survey that demonstrated that more than 80% of Rwandans had been waiting for the vaccine for a very long time. Epidemics on the other side of the world are a threat to all of us. No epidemic, it's just local. This is a quote that I love very much. If we ever have to face a similar threat in the future, we need to do much beyond our borders. We need to see Rwanda working day to day with Ethiopia, with Kenya, with Namibia, with Botswana, so that we come up with a global and well thought of approach with everyone participating for the common goal to timely control the epidemic. We had to protect our economy as well. This photograph was taken in the western border of Rwanda because Rwanda does a lot of trading with the DR Congo, and DR Congo, we did have differences in terms of preventing measure applications, mask here, no mask there, distance here, no distance there, but always find a way to have this conversation taking place because you have something in common to protect. As we speak, I am in the Western province in Rwanda, where I'm taking part in managing of the post-volcanic eruption in Eastern Congo. As you know, Nyiragongo is actively threatening the lives in the city of Goma and the city of Rubavu in Rwanda, but we keep the same standard. The refugees that we have coming in Rwanda, on top of whatever we are doing, we ensure that we give them the test for COVID and they follow the national guideline in terms of treatment. Thank you very much for this invitation, and I appreciate future collaboration that we are going to have together. Visit Rwanda soon. Thank you very much.
Thank you so much, Menelas, for that good presentation. And I'm sure there are many questions that should be coming on your side. Please insert them in the Q&A in the chat box. So the next speaker is Professor Asaya Kabende Gudina. Asaya Kabende Gudina is a professor of medicine and a consultant physician at Jimma University Institute of Health in Ethiopia. He graduated with a Doctor of Medicine in 2006 and completed his residency in internal medicine in 2010 from Jimma University. Professor Gudina has also received a postgraduate diploma in tropical medicine and hygiene from London School of Hygiene and Tropical Medicine, UK in 2011, and a PhD in international from Ludwig Maximilian University in Munich, Germany in 2016. He is teaching at Jimma University Medical School, besides serving as a consultant physician at Jimma Medical Center, the only tertiary teaching hospital in the Southwest Ethiopia. Professor Gudina is currently serving as a chair of Scientific Advisory Council for Jimma Emergency Operations Center for COVID-19 control. His major area of research are infectious disease with emphasis on antimicrobial resistance, but published over 45 scientific articles in peer-reviewed journals as a lead author or co-author. Welcome, Professor Gudina.
Thank you, Dr. Amukwe. Thank you for having me. As you see on this picture, I'm based in Southwest Ethiopia in only tertiary teaching hospital, which you can see here. And the one in red is our COVID treatment center, which has 10 mechanical ventilators and about 200 bed capacity. In this presentation, I will focus only on what we found from practical point of view during the management of outbreak in Ethiopia. And also I will show cases from my hospital where we accommodate patients from the whole of Southwest Ethiopia. We reported the first case of COVID-19 in Ethiopia on 30th of March last year. And then we had the first days about 3 weeks after that, which was a big news on the national media, mainstream media all over the country. But now we have, as of a day before yesterday, nearly 270,000. This is a fourth highest number of cases. The test positivity rate now stands at 10% out of the 2.7 million tests we have conducted. And then we had about 4,100 cases with a case fatality rate of about 1.5%. This is the epidemic curve we had from the beginning to the day before yesterday. I plotted. You will guess from what you see on this picture, Ethiopia had 2 peaks, but in reality, we don't know about the other peak because it most likely is an exaggerated peak because of the campaign we had last year on August by the name of Combat Community-Based Activity and Testing, at which time we started to test more than 20,000 a day from less than 10,000 for most part of the pandemic before that. So this time the number of cases increased with increment in the number of tests, and once the campaign stopped by the beginning of September, the case number stabilized for a longer time until the beginning of this year, which we think this is the highest and the true peak because the test positivity rate, which is relatively a bad indicator of the pattern of the pandemic in a country or in the places where you don't have a consistent and testing and consistent surveillance system. So our test positivity rate by March and April this year is close to 30%. And then we had the highest case number. Thankfully, now we are down the curve since the beginning of May. And I will not go in detail. I'll put this in 3 phases. Last year, we have a period of public panic where we did everything we could. And then in between, we had a period of, I think this is all the same, almost all over Africa and the rest of the world, where we had a period of negligence. We did not do anything. We lifted a state of emergency after 5 months in September, where we are having a large number of cases. And then by December, we're celebrating Christmas, Trippi and Epiphany, schools are opened. Then we have harvested the impact of our actions with the highest number of cases and days and ICU admissions, as you see over the last 3 months. At Jimma, where we treat patients from the whole of Southwest Ethiopia, we had so far tested over 35,000 with nearly 1,800 cases, 5% test positive, and we have reported 66 days, most of which happened in the hospital. And as you see, the number 3.8 is higher than the national average of 1.5. Maybe because we are the tertiary referral hospital, and currently we have 12 cases under follow-up at our hospital, most of which are severe, moderate to severe ones. Our guideline was contextualized from the World Health Organization, which mainly focuses on how to treat patients with COVID-19 and suspected with it, how to when and how to give oxygen therapy, dexamethasone, anticoagulation, and broad-spectrum antibiotics. This has been revised in September. We had the first in April. And it's also recommended the use of remdesivir if it is available. Unfortunately, it's not available. Unfortunately, for healthcare providers, like in my hospitals, we don't worry ourselves because it's too expensive to prescribe for patients. And in this part, I will focus on what the challenge we had. One of the big challenges we had is symptoms are unspecific, and clinical course is really difficult to predict. And what we expected it, COVID patients will present with the typical signs and symptoms, but most of our patients reported only low-grade fever, but they reported most, what they reported most is body aches, joint pain, chest tightness, particularly that worsens in the night. Fatigue is so severe that the patient cannot move from bed, and the other symptoms like flu symptoms cheated patients so that they presented to hospital late during the course of a disease. And most important, I think what the first presenter has already said, the first 5 days is a problem. Symptoms wax and wane, and I myself as a treating physician have witnessed this. We send patients home, we tell them your symptom may get worse, but they say, okay, next day symptoms improves and patient goes to hospital, workplace, because they didn't trust that they had COVID despite positive PCR, to return back after like day 7. And we found most of our patients who were admitted to the hospital were admitted between day 5 and day 7 and day 10. And as because of this, we had an increment in disease transmission to the community and also to our healthcare providers and disease severity, which was difficult for us to handle once the patient present is in the hospital. And the other problem we had is most severe cases were missed and treated in regular wards, because we were expecting patients to, like I said earlier, with typical symptoms. But what we found is patients with heart failure, with COPD, bronchial asthma, they presented with worsening of the underlying symptom without showing what we think as a classic sign of COVID-19. And some of the patients were treated as bacterial pneumonia cases. And some patients, in fact, most of the patients were treated in primary level care as a typhoid fever with antibiotics. And we found most of our patients who were admitted to the hospital, present to the hospital, on average after 7 days of symptoms of onset, and most of them have already taken antibiotics like ciprofloxacin before we showed at the hospital. Because of that, we think we underreported. I think this is also common to many places, including high-income countries. We underreported severe cases, and the risk of infection as a result increased to the patients in the hospital because we treated them in regular wards, and to the healthcare workers. Currently, we are conducting a survey of our healthcare workers. Among 200 and 510, we found 61% had SARS-CoV antibody. Thankfully, none of them were admitted to the hospital with symptoms. The other problem is silent hypoxia is a challenge. Unlike bacterial pneumonia, in which case we find our patients presenting with severe symptoms, even with a normal peripheral oxygen saturation, COVID patients, we found, I myself had a patient who had an oxygen saturation of 85% giving his history comfortably, until we found that he had hypoxemia. And one of my colleagues reported a person with 80% oxygen saturation was giving history comfortably. So that's a big problem, because patients die at home, and people say COVID results in 7 days because they don't detect the silent hypoxia. And this is an image from 2 of my patients. And on the left side, this is a 33-year-old man who did not have any underlying medical condition. That's a patient I stated earlier. And he came to hospital, he gave a specimen, and he just called me because I know him personally, just to tell me that he is suspecting himself having COVID-19. But we tested, and his saturation was 86 to 88%. And this is the CT scan. And that's what we expect. This patient would be having a severe disease, but he was relatively stable, and he needed only 5 days intranasal oxygen, and he improved. And the one on the right side, also a diffuse change on CT scan and chest X-ray, a 44-year-old man, he did not even need admission, and the oxygen saturation was 91 to 93% by the time he came to the hospital. Actually, he came on day 15 to me. He took dexamethasone in the hospital, in the community, without doing any test except the RT-PCR. Other is predicting patients at risk of severe disease is not as easy as it seems. We have seen an old person, 74, having diabetes, ischemic heart disease, hypertension, every risk you would imagine with the age, just to had normal CT scan with mild symptoms, while we had, the 2 cases I showed earlier developed clinically severe disease. And we also had 21-year-old, 29-year-old without any underlying medical condition who passed away because of COVID. And the other important thing is patients whom we consider as not having underlying medical condition actually had undiagnosed chronic medical condition like type 2 diabetes, hypertension, malignancies, which we discovered after patients showed up in the hospital. This is just an observation. It's a possibility of genetic or family risk factor, because when one family member was admitted to the hospital or died of COVID-19, we found that first-degree relatives being admitted or present in the hospital with severe disease, maybe you are thinking either there is something related to family risk factor for severe diseases. And this is also, I think, the challenge for everybody. The decision to intubate is a challenge for doctors, for family members. Sometimes we face difficulty to convince family members, well educated, because they know that the outcome is not good all over the world. And once you put patients on mechanical ventilator, outcome is not good. And so far, we intubated only 12 patients, and 10 of them passed away. And the dilemma now is, should we intubate as a desperate option, or should we intubate as early as possible? I cannot give up. Personally, I will not intubate patients as initial treatment unless we exhaust all the possibilities. And there is nothing good in COVID, but I will not choose septic shock because we never had success with septic shock. Once it occurs, it is inevitable that patients develop acute kidney injury, and when that happens, there is no way back. I personally prefer ARDS because we had relatively better success with an early treatment. And well, antibiotic misuse is well documented all over the world because our national guideline says use broad-spectrum antibiotics like amoxicillin, clavulanic acid, or moderate ones, and broad-spectrum parenteral antibiotics combination like ceftazidime with vancomycin or meropen, antibiotics which we don't often use in regular clinical care we use for COVID, and we have seen an overuse both in a primary level care and tertiary level care. A good experience we share is the early you start oxygen in high-risk groups with CT scan abnormalities, or if saturation drops below 94% with dexamethasone and anticoagulation, we have seen a very good outcome. We did not conduct a clinical trial, but from clinical observation, that's something we would recommend for high-risk groups. And the other is optimizing oxygen therapy. Unlike other patients, like with bacterial pneumonia, we gave intranasal oxygen, so nasal catheter, we wait until a patient deteriorates, but in COVID, we learned this sooner we start high dose oxygen, so face mask, better the outcome of the patient than the use of non-invasive modalities as early as possible. So putting into perspective from our experience, in-hospital mortality due to COVID is very high in Ethiopia, and particularly in the hospital where I work. There is a delayed hospital presentation that contributed to high mortality, and predicting clinical cause is always difficult. And early commencement of oxygen therapy and other supportive care is crucial. And we should be cautious in use of antibiotics for management of COVID-19, because so far there is no clear evidence for bacterial superinfection in COVID-19 patients. Thank you very much.
Thank you very much, Professor Kabende, for that insight that you've given us. We now welcome Professor Tang Kenjin from Sun Yat-sen University, where I actually visited in November, almost just 2 months before the declaration. Thanks to, I think it was sponsored by the university with the courtesy of Aga Khan University, Nairobi. So Dr. Tang Kenjin has a PhD in international medicine from first affiliated hospital, Sun Yat-sen University. She was a visiting scholar in the Division of Allergy, Pulmonary, and Critical Care Medicine, Vanderbilt University Medical Center, USA, between 2006 and 2007, and also visiting scholar in Simmons Comprehensive Cancer Center, University of Texas Southwestern, UTSW Medical Center, USA, between 2013 and 2015. She's currently a full professor and a deputy director of the Division of Pulmonary and Critical Care Medicine, and first affiliated hospital in Sun Yat-sen. She has been working on patient consultations and screening of training on epidemic prevention, control, etc. since COVID-19 outbreak. Her clinical interests are in respiratory infectious disease, lung cancer, and chronic obstructive disease. Welcome, Professor Tang.
Okay. Distinguished experts, it is a great honor to have the opportunity to participate in today's AAHCI East-West Africa webinar on COVID-19. Here, on behalf of the first affiliate hospital of Sun Yat-sen University, I would like to briefly introduce and review the management and preventive measures done by our hospital during the epidemic of COVID-19. I'm Professor Kejing Tang from the Department of Pulmonary and Critical Care Medicine in our hospital. This slide shows the overall epidemic situation of COVID-19 in China, showing the cumulative number of infections and deaths in China as of the 25th this month. We can see there are only 15 new confirmed COVID-19 cases, and they are basically imported cases from abroad. Therefore, the overall epidemic control effect in China is very satisfactory. And as of 23rd this month, a total of 510 million vaccine doses have been administered in China. So it is expected to achieve mass immunization against COVID-19 by the end of this year. But back to the end of December 2019, as you all know, an increasing number of cases of lower coronavirus pneumonia have been diagnosed in Wuhan, Hubei province, China. With the spreading of the epidemic, COVID-19 cases have also been reported in other regions of China. You can see last year, the vast majority of COVID-19 confirmed cases and deaths were in Wuhan, Hubei province. Our hospital is located in Guangzhou, Guangdong province. You can see there is a considerable distance between Guangzhou and Wuhan from the map. But because Guangzhou province is a province with a relatively high concentration of floating population, there were more and more patients from Hubei province with a relatively at that time. And the pressure on the prevention and control of the epidemic situation was also very great. So now I would like to report the measures and achievements in the fight of COVID-19 in our hospital. In the face of the sudden epidemic situation, our hospital responded quickly and immediately set up a COVID-19 leading group, a coordination group, and an expert group. The leading group is responsible for the leadership, command, and organization of the COVID-19 prevention and control work of the whole hospital. The coordination group is responsible for coordinating the transfer of patients, specimen delivery, epidemic reporting, and other works, and formulating the detailed prevention and control measures for COVID-19 in the whole hospital. The expert groups is responsible for the screening of suspected cases and the treatment of confirmed cases. These three groups held joint working meetings on a regular basis. The hospital leaders carried out on-site supervision every week to eliminate the potential hazards in time and guide the next work plan and the scheme. For staff training and emergency drill. In the face of COVID-19, an initially mysterious and deadly enemy, our hospital quickly organized a team of experts to carry out training with the whole goal of zero infection for the whole hospital staff. The training content is constantly adjusted and updated according to the latest guidelines, using the combination of online and face-to-face training. Online training is mainly therapeutical training, and face-to-face training is operational training. For example, a very important part of face-to-face training is how to properly put on and take off personal protective equipment and reduce the chance of infection while caring for patients with COVID-19. In order to ensure the quality of training, small class training is used in face-to-face training with less than 30 people per section, and the drills and the examinations will be carried out. This slide shows some things of various training and emergency drills conducted in our hospital. It is this strict broad staff training that enable the whole medical staff in our hospital to achieve zero infection. In order to timely adapt to the requirements of prevention and control of COVID-19, from January to September 2020, our hospital has formulated a total of 8 editions of handbook on management and prevention of COVID-19 and more than 30 special guidelines. These handbooks were brought to Wuhan by the first batch of medical teams in Guangdong province and were also translated in English and brought to Serbia when assisting Serbia in the fight against the COVID-19 epidemic. These guidelines play an important role in guiding the local epidemic prevention and control. In order to further prevent and control the epidemic situation of COVID-19 and strengthen the management of nosocomial infection, our hospital strictly implements the pre-examination charge system, set up pre-examination charge points, enhances the management of first diagnosis responsibility, improves body temperature monitoring, and carefully investigate the epidemiological history of patients from medium and higher risk areas. Our hospital is the first hospital in Guangzhou to carry out the COVID-19 nucleic acid testing, and we have a special CT examination room independently set up for patients suspected of COVID-19. This slide shows the treatment process of patients with fever in our hospital during the COVID-19 epidemic. We have a separate registration and charging window for fever clinic and a special access for fever patients. For patients with suspected COVID-19, nucleic acid test and CT examination are carried out at the same time. Patients with chest CT image changes that cannot exclude COVID-19 should stay in hospital isolation ward waiting for nucleic acid test results. Since our hospital is not a designated COVID-19 hospital, so if nucleic acid test comes out positive, the patient will be immediately transferred to a designated hospital for isolation treatment. As I just mentioned, our hospital has carried out COVID-19 nucleic acid testing since January 21st, 2020, which is the first hospital in Guangzhou to carry out the test. At present, a total of more than 350,000 nucleic acids have been tested, with an average of 1,000 samples per day, with a maximum of 3,000 samples per day. The accuracy of nucleic acid testing is 100%. Our hospital currently has a testing capacity of 10,000 samples per day, and it can reach 30,000 samples per day in case of emergency. And we also support nucleic acid testing in Beijing and Hong Kong. During an epidemic period, many patients felt confused because they could not get timely diagnosis and treatment. So our hospital opened free internet consultation on January 23rd, 2020 to answer questions for fever patients. It is one of the first hospitals in China to open free fever clinics. By communicating with specialists in the form of online consultation, doctors can preliminarily judge the possible cause of fever through symptoms, reduce the unnecessary hospital visits and the risk of cross-infection. At the same time, to ensure that suspected patients can go to the hospital in time to receive standardized diagnosis and treatment to avoid delay. As of May 25th this month, there were more than 3,000 internet fever outpatients and a total of 57,000 internet medical consultations in our hospital. Our hospital is one of the first hospitals in Guangzhou province to dispatch medical teams to assist the Wuhan, Hubei province. Since New Year's Eve last year, the most important traditional festival in China, our hospital have sent 3 groups of 150 medical team members to support Wuhan. The longest team these experts have worked in Wuhan was 61 days. They have overcome many unimaginable difficulties and successfully treated a large number of critical ill patients with COVID-19. They made outstanding contributions to China's victory in this fight against COVID-19. In addition to sending medical teams to the front to fight COVID-19, our hospital regularly organized top medical experts from several affiliated hospitals of Sun Yat-sen University to conduct the MDT consultations through the high-end telemedicine center of our hospital. We discussed and formulated the best diagnostic and therapeutic strategies for critical ill patients in Wuhan and also other areas of Guangdong province, which significantly reduced the mortality rate of COVID-19 within these hospitals. In addition to assisting in the fight against the epidemic in China, our hospital also sent two medical teams to Serbia to assist the fight against COVID-19. And I'm very proud to be one of the experts in this medical team. We fight the COVID-19 pandemic side by side with Serbian medical staff for 18 days, shared our experience gained in China and especially in Wuhan. We visited 22 cities with a severe epidemic situation in Serbia. We went to many places such as COVID-19 hospitals, elderly care facilities, and child care centers, participated in more than 150 activities and traveled more than 20,000 kilometers. The joint battle against the pandemic had strengthened the ties between China and Serbia, and the Chinese expert medical team to Serbia became a symbol of the friendship between our two countries. This slide summarizes the medical teams dispatched to support the fight against COVID-19 in China and abroad by our hospital in the year 2020, with a total of 192 medical staff from 11 medical teams. While fighting against COVID-19, our hospital has also done a lot of related research and published many papers to introduce China's experience and achievements in the fight against COVID-19. In British Medical Journal, one of the 4 major journals of clinical medicine in the world, the team of Professor Haipeng Xiao, the president of our hospital, expounded the importance of training medical personnel to effectively use protective equipment to fight against COVID-19. It was officially recommended by BMJ in a variety of forms. Among the 15 million research results included in the statistics, its reading ranked in the top 5%. This final slide summarized our work in fighting against COVID-19. After arduous efforts, we have made outstanding contributions to China's and even the world's fight against COVID-19. And we have ensured zero infection among medical staff in our hospital, zero missed diagnosis, and zero spread of COVID-19 patients. Thank you very much. Let's look forward to the whole world's victory against the COVID-19 as soon as possible.
Thank you very much, Professor Tang, and all the other speakers who have given very interesting and nice talk. I'm sure there are very many questions, and I'll seek your indulgence how long will take. My idea was that we are supposed to have closed by 6:25. We probably go up to about 6:40. Whatever we have done, we'll have answered. Whatever we have not answered, we post it to the website, all the answers. Some of the sample questions that were here to all the panel speakers is, how will your management team be better prepared for a future crisis as a result of COVID-19 pandemic? Will you make changes to your crisis management team? And did any new leadership positions come out of the pandemic at your academic center? Can any of the panelists just, or can I put the first one, any panelist can answer, and then we can go to the next one. How will your management team be better prepared for future crises as a result of COVID-19 pandemic? Manelas, I saw that you had even current and future plans of how to, probably you can take a try on that one.
Thank you very much for the very well, actually very difficult questions. Looking what we have just lived and looking what we have lived in the past, I confess I'm not very, I haven't seen enough of the past, but there is a lot that we see in the documentation. But I have lived two pandemic of great magnitude. The SARS-CoV-1 actually was in China. In medical school, then SARS-CoV-2 finds me in medical practice. And I see in the future, there's going to be a greater of more involvement of academia, at least for the side of Rwanda. We did not follow very much in terms of research that was sent out there for people to benefit. For reasons that we have all seen, we did not have the great cross-border collaboration that we should have had. At least within the East African community. So these are the lessons that you are going to take onwards, because disease no boundaries, and there are things that connect us, either you want it or not, the cross-strait. For example, the first patient of COVID-19 who died in Rwanda is a cross-border long-haul driver. Who have to move commercial items from the Tanzania and move along, do deliveries in Rwanda and continue to Congo. He did that during the COVID time until the 5th times when he got COVID and died from it. That was the first patient that we had. So there is going to be a lot of collaboration cross-border in my understanding. Thank you. Over to you.
Thank you so much. I know the others who want to add to it, but because of time, I think I'll ask the next questions to Professor Gudina. Will you make changes to your crisis management team?
Yes, sure. Well, this is related to the previous one. There are now policies coming at universities and university taking the leadership. Our university took the leadership to control the pandemic in the whole of Southwest Ethiopia with a population of over 20 million. So this is what we are just, we are brainstorming grants like pandemic preparedness grants, pandemic preparedness office at universities and the Ministry of Health. So this is something that we are brainstorming, but for sure there will be something that will come out in the future.
Thank you so much. Now I probably can go back to Professor Tang. I know China was very organized, and we need to learn from you. Here you are talking about zero, and Kenya, we are waiting for the next wave very soon. But did any new leadership position come out of the pandemic at your academic health center? Or were they just, was it just as you're already prepared long before the pandemic? Professor Tang?
You mean, I'm sorry, could you repeat your question? So you asked where our hospital is prepared for the future epidemic, or I'm sorry?
During this particular crisis, a lot of other new leaders came in, new players came in. I don't know whether it was a similar thing in your hospital, or you already were prepared and the same leadership just took over and ran with it.
You mean
the response to pandemic?
Yes, our hospital still implement very strictly prevention and control measures for older patients. So we screened all the fever patients through the fever clinic. And I think we are prepared for the future the future situation.
Okay, thank you so much. Dr. Rina Shah, Prof, how can academic health centers better collaborate to help us prepare for future pandemics? Now that you sit in the national, you know what other academic areas like Nairobi universities, Cambridge, other places, how can they, and Aga Khan, how better collaborate to help us prepare for future pandemics or crises?
I think all academic centers have know what their strengths are and their weaknesses are. And I think there are lots of forums where we come together, this is of course one of them, but there are others, the societies where we speak. There's the Infectious Disease Society, which is well represented by a lot of the academic centers. There's the Physicians Association. So there are many forums where you can come together, and the national task forces. And to come and say that this is what we're doing, this is what we're good at. So some institutions are strong in research, some are good in clinical excellence, some have more, like we have a training, we have infectious disease training. It's how we can come and work on each other's strengths and see how we can improve the care together. I think we're all doing it in different forums, but it's for countries to come together and say, this is what we can do. And of course, I think where Africa lags behind is research. Of course, like Kemri, where you come from, is where we look up to in terms of research, but I think all of us should try and raise to that occasion to do collaborative research. We've started doing that. There's already a couple of projects that we're doing with Kemri in COVID, in HIV, and I think there is working on each other's strengths. The Kemri collaborators reach out to us and say, this is a clinical scenario, would you be interested? So I think it's working together, and not just country, even regions, even continents. This pandemic has to bring us all together, to work together, to improve, to bring us all up to a certain level so we can compete with the West in terms of academic excellence, clinical excellence, and what we do. And I think we can get there.
Thank you so much. I think I'll take a few sample questions from the chat, and then probably any of you can jump in. One, in our region, Rwanda, Kenya, Ethiopia, have we had any case of black fungus disease locally? Can one person answer very?
So we have, so at least in Kenya we haven't. I don't know about the rest of the countries, but don't think so.
Ethiopia, have you seen any?
Well, we didn't culture, but what we found, one case, and a patient who was admitted to COVID treatment center after she had cesarean section. She improved from COVID, the PCR was negative, and then like after about 4 weeks, she developed worsening of symptoms, and we did CT scan, and she had fibrosis. And we thought it was TB. We started on anti-TB, and we could not confirm it by gene expert, but we thought it was fungal superinfection because she took dexamethasone for 28 days. That was the only, well, clinical impression. Otherwise, we did not confirm anything.
Thank you so much. From Rwanda, Professor Menelas, are you administering monoclonal for early stage COVID?
Yeah, we do use monoclonal antibody in high-risk groups. Like there are people that right at diagnosis, you know that their clinical trajectory is going to be very bad, diabetic, they're on stage 4 disease, have heavily invested in chemotherapy. So straight away, we just give them monoclonal antibodies. We are soon releasing the data of our experience of monoclonal antibodies, but it did save a lot of lives that would have lost without it. Yeah.
Thank you so much. Both of you, all of you actually said most of the drugs are probably placebos. Now, Shah, these messages, is it just in our heads, or has the community been sensitized? This is from Rajiv Shah, asking the panelists.
Sorry, I didn't, is this for, I didn't understand the question. Is it the?
There's still a lot of prescription of antibiotic, azithromycin, vitamin D, COVID-19. You remember even there was a shortage of citrus fruits because of COVID. And you have just shown that most of them have not, there's no clinical evidence that they're working. that particular information, has it been disseminated wide enough?
So we're trying. I think we are trying to do it, and through the hospital, through Infectious Disease Society of Kenya, through KAP, where we're trying to get that message across. We have our, like I said, we have our protocols, but it's very difficult because in countries where you can go and buy any medication you want over the counter, patients are just going and buying. Often by the time they come to see us, they've been to the pharmacy and bought the Zithro zinc. So we have reached out to media as well to see if we can do it, but I think it's going to take time. And we really don't want to go down the route that India has gone, because India is seeing a lot of issues with the indiscriminate use of a lot of these drugs. So I agree, it's a message that needs to go, but it's going but slowly. Thanks.
Thank you so much. We could talk until tomorrow, but thank you. This was a great session and discussion. Attendees would appreciate if you take a minute to provide your feedback in the evaluation to help them regionally for planning for future activities. So we hope all those questions will be answered. Without further ado, I'd like to give the floor to Professor and Dean of the Aga Khan University Medical College, East Africa, Professor Lukoye Atuoli, to give the closing remarks. Professor Lukoye.
Thank you very much, Evans, and thank you all the panelists for very, very enlightening discussions. I think this has demonstrated that we need to do this more often. We need to share insights more often. I have seen a lot that's more common across our sites than what is different. And this just demonstrates that we are all committed to using the best evidence available. As Rina said, I think it is important for us to leverage from the strengths within this network. Let us identify who is strong in what. We know Cambridge is very strong in research, and other institutions are doing very well with clinical governance and so on. I think this is an opportunity for us to leverage that those resources within the network in order to ensure that our patients get the best care, but that we also generate the new knowledge that is necessary in order to continuously improve care. So I think this session has been a great success. I want to thank William and your staff, your team, for putting this together. Elizabeth, thank you very much for being part of this entire process, and really grateful for you all. Importantly, this would not have been as useful as it has been if we didn't have the participants, the members of the audience who have been active participants in my view. I have seen many of the questions that they have asked, some of which probably we will have to respond to through other means because of time. But I think all this is testament to the fact that we need to do this more often, and over to you in the Secretariat to start thinking about how often we should do this and how much more we can do. So thank you very much for a very wonderful session. Thank you.
Thank you very much. Unless Professor William, you want to say something as we close?
Thank you very much. Everything has been said. The session has been excellent. I have nothing more to add besides what the Dean has stated. So thanks a lot, and have a nice evening or morning in China. We look forward to the next session. Thanks.
Thank you very much, and bye-bye.
Bye.